Welcome back to the deep dive. Today we're jumping right into some really fascinating material from Dr. Raju's YouTube series.
We are. Specifically, his video HCC 147517A Cold Snare.
Right, and it feels like we're looking at a corner of endoscopy that is, well, it's deceptively simple on the surface, but incredibly demanding in practice.
It really is. It's a great deep dive into technical mastery.
Our mission today is all about precision. We want to understand why this cold tool is even a thing, how its success depends entirely on split-second timing, and, what happens when that technique breaks down.
And what Dr. Raju shows so well is that sometimes the tools with the least tech, no electricity, no software, they demand the absolute most from the people using them.
I love that. We're not talking about lasers or robots today. We're talking about a wire loop that cuts. And that central idea is that it's cold. In a world of electrocautery, why would you give up the power of heat?
That's the million-dollar question.
So let's start there. What is the cold snare's primary job?
Its main purpose is resection, specifically the quick and complete removal of small polyps.
Okay, so what size are we talking about here?
We're generally talking about lesions that are between, say, 3 and 8 millimeters. These are the really common, smaller growths where the goal is just to get it out, one and done, curative removal.
That makes sense. Your standard screening finds. But what I found fascinating were the other jobs this tool gets pulled for.
Oh, absolutely.
Yeah.
Its versatility is surprising.
So what are some of these secondary uses?
Well, because it's purely mechanical, it's actually a fantastic retrieval tool. For example, it's pretty routinely used to grab and remove plastic stents from the bile duct or pancreatic duct after they've done their job.
So it's like a little lasso.
A very precise, sharp lasso, yes. It can make these targeted grabs in really tricky spots.
But the tertiary use is the one that really got me. Removing long ingested foreign objects.
It's true. And it's a real challenge. You think about things like a pen or a pencil, sometimes ingested by patients with certain psychiatric conditions.
And a normal tool can't grab that.
It's incredibly difficult. The length, the smooth surface, standard baskets or forceps just can't get a grip. The cold snare can loop around it.
Wow. That elevates this thing from a surgical tool to a high-stakes retrieval system. But whether it's a polyp or a pen, it all comes back to that one word, cold.
Exactly. This is the central point. When most people hear snare, they immediately think of a hot snare.
The one that's plugged into a machine.
Right, an electrosurgical unit, or ESU. The heat from the wire cauterizes the tissue as it cuts. The cold snare has no connection, none at all.
So the way it works is just completely different. It's all about force and precision.
Precisely.
Yeah.
It removes tissue by what we call mechanical transaction. The best analogy for it is a guillotine effect.
A guillotine, it's just slicing clean through.
It's just physical tension and the sharpness of that wire.
And this, for me, was the big aha moment. Because there's no energy, no heat to seal up little bleeders or to sort of forgive a slightly off cut. The human technique has to be perfect.
Absolutely perfect. The machine's simplicity is compensated for entirely by the team's execution.
And that starts with the teamwork, which is this kind of high-pressure choreography between the endoscopist and the assistant.
100%.
Let's focus on the assistant's role first, because it's so specific and it all hinges on one thing: speed.
It really does. The assistant is the one who closes the snare. So when the endoscopist says cut, they have to do it fast.
And this isn't just about being efficient. There's a physical reason for it.
There is. It's physics.
But wait a second. If it's a mechanical cut, isn't there a risk that going too fast makes you lose precision? How do you keep it accurate?
That's a fantastic question. The speed comes after the placement is confirmed. The endoscopist locks it in place first. We'll get to that. But that speed in the cut is critical.
Why?
Because if the assistant closes the snare slowly, the wire doesn't slice. It starts to drag.
Dragging. So it's more like tearing than cutting.
Exactly. It's messy. It's incomplete. You're tearing through the submucosal tissue instead of getting a clean transection.
And that means you're leaving a ragged edge.
A ragged edge, an incomplete resection, and potentially more risk. You want that crispness of a guillotine, a single clean slice. The whole team has to know that microseconds matter.
Okay, so the assistant's mandate is speed. Now let's talk about the endoscopist. What are they doing right before that cut to set the stage?
They have two really vital tasks. First is the inclusion zone.
Meaning what they capture in the loop.
Right. You can't just lasso the polyp itself. You have to include a little bit of the normal, healthy pink tissue that's surrounding it.
You want to capture the base of the mountain, not just the peak.
Perfect analogy. And then the second step is maybe the most important technical point. The flagpole technique.
The flagpole technique.
You take the plastic sheath of the snare and you post it. You press it firmly onto the mucosa at a slight angle.
So the plastic tube itself becomes an anchor. Why is that pressure so critical?
Because it fixes the sheath in place. It's like putting the brakes on. It stops the entire device from sliding forward when the assistant starts to close the loop and apply that tension.
Ah, so if you don't anchor it, the whole thing just gets pushed off the target.
It gets pushed forward. You end up just skimming the top of the polyp instead of cutting cleanly underneath its base.
And if you do that, you're leaving behind the most important part, the base where it could grow back from. The flagpole ensures you get the right depth.
That's it. It assures you cut where you intended to cut. Then after that fast guillotine cut happens, you have to check your work.
And there's another great visual for this. You're looking for the sunny side up of an omelet.
It's a great way to remember it. The spot where the polyp was should look like a clean, pale circle, that's the white of the egg, surrounded by a perfect ring of normal pink mucosa. The yolk is gone.
And that visual tells you that you got a complete en-bloc resection.
The whole thing in one solid piece, which is exactly what the pathologist needs to look at it under the microscope and say, yes, this was curative.
Okay, that all sounds great when it goes right. But let's talk about the decision-making. When do you actually choose this simple tool over something more complex?
Right, because this connects the technique directly to the potential pathology. It's a risk-reward calculation. You only use the cold snare on small, flat polyps that look, to the eye, completely benign.
So no features that look like cancer.
Exactly. No ulceration, no hardness, nothing that looks suspicious. Because the cold snare, by design, gives you a pretty shallow cut.
How shallow are we talking?
You're usually just removing the mucosa, maybe scraping the top of the muscularis mucosa, which is a very thin muscle layer. For a simple benign polyp, that's perfect. You get the cure with minimal risk.
But the second you see a red flag, anything that suggests cancer, the whole game changes.
The whole approach has to change.
Why can't you just use the cold snare on a small early cancer, get it out quickly?
Because of staging. It's all about staging. If you even suspect cancer, your goal isn't just removal, it's diagnosis. You have to know exactly how deep that cancer has gone.
And the shallow cut from a cold snare won't tell you that.
No. You might have removed the part you can see, but the pathologist can't tell you how deep it was, which is what determines all future treatment.
So what's the alternative then?
You have to do what's called a lift and resect. You actually inject a fluid, like saline, underneath the polyp.
To create a buffer.
You create a cushion, yeah. It physically lifts the polyp and the tissue around it up and away from the deeper wall of the colon.
And that lift lets you get a much deeper bite.
A much deeper resection. You get a big chunk of the submucosal layer underneath. And that depth is everything for the pathologist. They can measure the invasion down to the micron. That information determines if the patient needs surgery or chemotherapy or just surveillance.
So you trade the simplicity and low risk of the cold snare for diagnostic certainty.
It's a critical trade-off.
Let's tie this all together by comparing the cold snare to another tool that seems similar, the cold biopsy forceps. They're both cold, but they're used for totally different reasons.
This is a really important distinction. It can be confusing. Cold biopsy forceps are for sampling.
Just taking a tiny piece.
Just a pinch. For diagnosis.
Yeah.
If you try to remove a whole small polyp with biopsy forceps, piece by piece, you have a very high chance of leaving some behind. The resection is almost always incomplete.
So to put a fine point on it, if you see a tiny benign-looking lesion and your goal isn't just to test it, but to cure it right then and there,
To remove the whole thing, en bloc.
the cold snare is the right tool, but only if that technique, the anchoring and the speed, is absolutely flawless.
It's the optimal tool for that specific job.
Mm-hmm.
The completeness of the cut is everything. You're giving the pathologist the whole story, not just a few pages.
This has been a really, really fascinating look at a specific process. We started with Dr. Raju's video, and we learned that this simple tool, just a wire loop, is actually one of the most technically demanding things in the toolkit.
It is. Its success hinges entirely on that coordinated speed and that immovable anchor.
The key takeaway is that in these highly technical fields, the difference between success and failure can come down to microseconds.
The assistant has to be a guillotine, and the endoscopist has to be a flagpole. That two-step rhythm is everything.
So what does this all mean for you, whether you're in medicine or not? We've just seen this huge contrast between a tool for a curative resection, the cold snare, which aims for that complete en-bloc removal, and a tool for just sampling, the cold biopsy forceps.
The goal of the procedure completely changes the tool you pick and the precision you need.
And that leads to a final thought for you to consider. We've seen that when dealing with the human body, aiming for en bloc removal, a complete solution is the gold standard.
So think about how often in other complex fields, managing a project, debugging code, analyzing data, we rely on a quick, partial sample of the problem. That little biopsy might give us some information, but it almost never leads to a complete resection of the underlying issue.
It seems like that principle, that you have to address the entire scope of a problem to truly solve it, is pretty universal.